Thank you. Thank you so much, Carol. I want to thank you for the invitation. It's very exciting to be at this engaging event, and also to extend my appreciation to your staff for all of the support during the planning. So my goals today are to start by defining midlife, talk about this important point in the lifespan, go into some research that maybe presents some distressing or signs of despair processes that are happening in this point of the lifespan, and also focus on some positive aspects. We'll be looking at close and intimate relationships. I'll present some work that links health in midlife to romantic relationships in particular. I'll conclude by talking about implications with some take-home messages, and then we should have a little time for discussion. When I define midlife, I look to the organizations such as the American Medical Association and the CDC that consider the ages of 50 to 64 to generally represent midlife. You'll see that some of the studies that I present use a wider or somewhat narrower age range, but we're looking at this middle adult period. I think more importantly, the qualitative differences that occur during midlife are familiar to all of us. We see tremendous health variability emerge as people enter the late 40s, early 50s. 70% of individuals enter their 50s with at least one chronic health condition. We see an increase in daily challenges, more competing demands on individuals' time. On a more promising note, midlife also offers the opportunity for people to engage in more dynamic and additional roles. There's a high potential for success and productivity. This is where we see people shift to making sure that their life has meaning for people outside of them, maybe giving of their time more, turning into a mentor as well as a worker. And not surprisingly, this period of midlife has been described as a pivotal period. Midlife is the time in life that links earlier development to later development. It's also the period of the lifespan that links younger generations to older generations. So this truly is a time where we pivot and see tremendous growth and change. The attention given to midlife is highly warranted and just continues to increase as well. So we know you've heard these statistics, but more people will be of retirement age, more people will be working longer, we're living longer as a society. So how people do during midlife holds tremendous importance as we look to the future. There are some critical research needs. And you've heard our first two speakers mention the National Institutes of Health a couple of times throughout the presentations today. And the NIH, just underscoring how important this period is, has calls for research specifically focused on understanding midlife better than we do now. We need to understand what allows people to develop and age in a healthy way. And we need to better fill in our understanding of the human development life course. So looking at development research overall, we know a lot more about other periods of the life compared to this period we're talking about, midlife. And developing a better understanding will help not only people who are in mid-age, but also the younger and older generations who rely on this period. If you have heard research lately that focuses on mid-age, it might stem from one of the studies that I'll be focusing on today. And I'm talking about a deaths of despair study. And this is actually referring to a couple of papers that were written by two economists at Princeton, Ann Case and Angus Deaton, who used statistics, the all-cause mortality statistics from the CDC, and looking over about a 15-year period. and identified, very importantly, that death rates for white, non-Hispanic adults at midlife, in this period we're talking about, were rising, not falling as they had in the past. When the researchers dug into why this was happening, these increased deaths were largely accounted for by rising death rates due to drugs, alcohol, and suicide, so the term deaths of despair. These economists said that they were both surprised and disturbed by the magnitude of these findings. They also extended their work and brought in other data from different countries to show that the United States was uniquely falling behind. So while other similar countries were making progress in mortality and morbidity, the United States was falling behind. And they showed that these differences were particularly impacted by education and socio-demographic factors. Not surprisingly, those broad findings have encouraged just a lot of additional work to understand what is happening. A recent paper by researcher Dr. Lauren Gaydosh took a slightly different approach to the question. So if you remember, the Case and Deaton study looked at the outcomes of people at one point in time when the CDC had their death records already. This research team took a different approach and took advantage of the AdHealth study, which might be familiar to you. It's a large, nationally representative study that started tracking individuals when they were in high school and has followed them now until these individuals are entering their 40s. For this particular study, the research team looked at indicators of depression symptoms, so feeling blue or feeling down, sadness, suicidal ideation, thoughts of harming oneself or killing oneself, marijuana use, and heavy drinking, clearly indicators that would map onto the signs of despair. And again, this study is different in that they're following people who are still alive over time, so it's a different type of design. These researchers recently reported that each indicator, each despair indicator looked at, increased over time as this cohort aged as they were approaching their 40s. So this is looking at people who are approaching midlife, showing increases over time in these signs of despair. Also notably is that this research study did not point out differences in education, geography, or racial and ethnic background characteristics. So we're seeing more consistency in this new cohort. If you can see on these studies, these are studies that are just coming out. There's a lot more work that needs to be done on this, it's an example of how we can look at the same question using different designs and different data. Case and Deaton were economists. They described their findings a lot in terms of economic opportunity, the labor market, social structures like marriage not being as common. Other people have argued that these changes and increases in mortality can be attributed solely to the opioid epidemic that we hear about all of the time. The figure on your left simply shows the increase in mortality overall, so not divided by any age range, but just the remarkable increase in the number of deaths related to opioids. Midlife period represents an extremely risky or susceptible period that we should focus on for a moment. Individuals in midlife receive the highest rates of prescribed medications. I mentioned before there's tremendous variability in health conditions and health symptoms. And as we age, we're more susceptible to adverse effects of medications or interactions among medications, or medications interacting with other things, like alcohol, for example. So we need to understand what's happening in midlife. Just a local importance about this epidemic. Even though prescription rates, actual medication rates, have declined significantly in recent years, 2017 we actually saw the most overdose deaths ever recorded. The city of Milwaukee is on track in 2019 to record their greatest number of deaths related to opioids in the past decades. And again, that's despite all of the public health attention we've seen, as well as prescription rates going down. So this is a problem that is absolutely ongoing. And another way that we can look at this issue, instead of focusing on mortality or deaths related to the opioid crisis, is to maybe take a step back and look at prescription drug misuse, which in many cases precedes overdose deaths. Prescription drug misuse is defined as using somebody else's medication or using your own medications in ways other than intended or prescribed. There's an important study by Dr. Ty Shepis and his colleagues where he drew on nationally representative data from the National Study of Drug Use and Health. And in that study, they simply ask about all medication use and then how it was used. So you get a really thorough look at what medications people are using and whether they use the medications according to their prescription or not. And in this particular paper, the researchers were linking medication behaviors to problematic consequences, and here, suicidal thoughts. So I'll start by reporting that when midlife individuals, and this study focused on individuals in midlife, and looked at particularly risky medications of opioids or pain medications and benzodiazepines. Again, those increase and are prescribed more at older ages. And the researchers found, when looking at suicidal thoughts, that appropriate use of those medications among individuals in this period was not related to suicidal thoughts. So people who used those medications in ways consistent with how they were prescribed for them did not have an association with suicidal thoughts. What this figure shows is that when individuals reported past year opioid misuse or benzodiazepine misuse, they experienced higher rates of suicidal thoughts in the past year. And when individuals misused both of the medications in the past year, 25% of those individuals in midlife reported experiencing suicidal thoughts in the same period. So it shows the importance of looking at the behaviors that may lead up to the overdose deaths that we see. I want to acknowledge that this process is very complex, and I'm just kind of touching the surface here because I don't think we can talk about these general trends without acknowledging this ongoing crisis. One of the most compelling papers that I've seen on this issue was published in Science last year and looked at a lot of complicated data gathered in the United States over time and actually shows that the opioid epidemic is simply part of an exponential curve that has been going on for generations and is forecasted to continue unless major changes are made in public policy and the way we research and treat these behaviors. Okay, so perhaps another area of midlife that deserves attention is romantic relationships. And when we look at some broad-scale research, again, we see that romantic relationships are challenged in this period of the life as well. Between 1990 and 2010 in the United States, the overall divorce rate remained flat. However, middle-aged and older individuals showed significantly increasing divorce rates. This research was conducted by Susan Brown and colleagues at Bowling Green State University, and not surprisingly, they were very curious about these broad trends and used additional data to try to uncover what was going on here. And while they originally hypothesized that maybe family transitions or personal problems like chronic illness, maybe there were some characteristics in the family or related to the individuals that could predict divorce, they did not find those associations. Rather, they identified that it's the more traditional structures and factors like marital quality being lower, economic resources being lower, that were more predictive of midlife and older adults experiencing divorce. So far, midlife might not sound like a very promising time, but fortunately, there is a wealth of research, as Carol mentioned, looking at sociological and psychological factors that shows us that close relationships actually do quite well in this period. And perhaps because the least satisfying relationships have already dissolved, partners do report high relationship quality. When we look at different types of relationships, parent-child relationships, relationships with community members or peers, conflict tends to go down and satisfaction and positivity tend to go up. There's work that shows that people get skilled at seeking out positivity. We learn how to kind of let go of some of the negativity and seek out better situations. And really interesting is research by Karen Fingerman and colleagues that shows that these improvements don't only come because individuals get better as they age, but you're likely to be interacting with people who are similarly aged. And so you're getting kind of a dyadic boost as well from being close with and socializing with similarly aged people who are also developing these skills and seeking out positive experiences as well. Okay, I'm simply using this as my reminder, so I will show you, I'll walk you through the results of this study. Just to give you an example of how we know some of these trends. Okay, so think about a study, and anyone could participate in this, where the researchers asked you to talk about how you would solve different problems. And some of the problems that you would be given would be instrumental. So they would relate to you needing to do something or fix something. So examples would be, you have a recipe to make something and you need to make half of what the recipe calls for. How would you figure that out? Or you spent time filling out a complicated form and it was returned to you. It wasn't accepted. So those are things you would have to figure out on your own or related to you. There are also interpersonal problems. So examples of this would include, a friend criticized how you handled something with your grown daughter. How do you respond to that? Or you're competing for a promotion at work with a colleague who you really get along with. So think about how you might handle those different situations. And in a particular research study, they trained the research assistants to code the different answers that the respondents gave. Some of the participants were younger, and some of the participants were older. The responses, even though people were giving all different types of answers, could be coded according to similar themes. And there are 4 broad types of solutions that people engaged in. One would be more of a withdrawal, and this is something that is like denial. So you're kind of suppressing it. You're not really dealing with this problem that was posed to you at all. Then there's more of a passive dependence, and this could be also where you're not working to fix the problem or do anything, but maybe having somebody else take care of it. Moving toward the other end of the spectrum, you could be really active and just do things to try and fix the problem. And that's called planned problem solving. Or you could kind of engage in an analysis and be even more planful and maybe weigh different ways you could respond and the potential outcomes of that. So think of those as the continuum of responses. On the left hand of the figure, you see the darker bars show younger people's responses and the lighter bars show older respondents' answers. And you see in response to the instrumental problems that most people were using those planned activities. And there's, not tremendous variability. People were kind of going up and down. When you look at the interpersonal problems, though, this is where it's really interesting. So remember that the bars on the far right are those best responses, showing that the respondents are engaged with the problem and working through what's going to work out best. And there you see that older individuals are using more of those helpful and active responses when faced with these questions, and doing a little better than the younger respondents, across all of the categories. And so think about this. This is showing that as people age, we're able to draw from our experiences, think about things in a very complex social and emotional way, and apply that to real-world settings. And these results are especially important because many tasks that you might administer to younger and older participants, the older participants might not look like they're doing as well, but they're actually, we're able to kind of capitalize on our experiences and use that in our favor as we age. Okay, here's another kind of landmark study that I'll take a moment to set up and then describe the results. This is called the heart failure study. So a team of researchers invited couples in which one member of the couple had congestive heart failure, so very serious long-term health problems that they were facing. About 200 couples came and met with the research team, and the researchers simply asked each couple, talk about an issue that you're working through or something that you're facing in your relationship for about 10 minutes. And they recorded these conversations. The research team then looked at all of these different interactions and discussions and coded which couples were using more positive expressions in their discussions, which couples were using more negative expressions in their discussions, and also incorporated a standard relationship satisfaction measure, and took the almost 200 couples and labeled them, you're a happy couple or an unhappy couple. Okay, so that's what we have starting the study. For 4 years then, the research team simply watched the death notices as public records and identified when the patients in those relationships had passed away. 4 years after those initial discussions, look at the difference in who remained alive. So my y-axis here is proportion alive. If you were in a happy relationship, you were significantly more likely to be alive at the end of that reporting period. And so clearly, we can use our relationships to our advantage in even just the most important health outcomes. It also shows me that if there's something I can do to understand what are people talking about, what are the differences in what people are doing when they have those relationship issues, then I want to be very motivated to try to figure out what we can take away from that. So I will highlight here that conflict in relationships is a particularly important indicator of how the individual partners develop, how the relationship develops, whether that relationship is likely to continue or not, and how couples handle their conflict impacts people around that relationship, especially children. So I've been part of a collaborative research program where we look at couples' conflicts as they occur. We developed a diary where partners are able to tell us very specific information about the conflicts that they engage in daily life. What I will note about this is conflict sounds very negative or has a negative connotation. When we're describing the research task to our participants, we don't use the word conflict or fight because we want to hear about all the ways that couples work through their differences. So think of these discussions as it could be any time that you're working through a difference of opinion with your partner even. I had support from the graduate school here at UW-Madison to conduct this type of research on 55 couples from the community who had gone through the empty nest transition. So while our earlier work focused on couples living with younger children, this study looked at couples in midlife who were no longer living with children in the home after they had raised one or more children together. This study was also the first to implement a diary on an iPad, so we went from a paper and pencil version to an iPad. In this sample of couples who were relatively, happy and well-functioning, the most frequent sources of the disagreements that they had in daily life included communication, habits, and chores. And for comparison, when children were in the home, the most conflict were children, chores, and communication. So children leave, but the chores stayed, it looks like. We asked about all sorts of things. Who started the discussion? How long did it last? What strategies did you use during the discussion? And so we were able to see which conflicts lasted longer in couples' daily lives. And those that dealt with money, children, leisure, and personality were lasted longer. We also looked at these were all different sex couples. So we looked at what did the male partners say their partners brought up, and what did the female partners say that their partners brought up. And so males said that their female partners brought up issues related to habits and relatives. And females, interestingly, said that their partners were bringing up discussions about communication. You'll see that neither partner said that they were bringing anything up, even though they could have. The topics that were described as old are coming up multiple times, so this wasn't the first time we talked about it. That included money and habits, not surprisingly. And then new conflict discussions included leisure, so you can imagine what those looked like. I think people are very interested in talking about these topics, and they are interesting to know, what we talk about. I think what's really critical to understand is how do we handle the different topics that come up. So conflicts concerning communication and habits were handled in particularly angry ways. And that's probably how you think of conflict, just more negativity, just maybe some criticism, but that might be your more typical view of conflict. Conflicts about children were handled in a relatively depressive way. Depressive conflict is different. It involves more sadness, maybe withdrawal, but less positivity. And then conflicts about leisure and friends were handled in relatively constructive ways. So more positive affect, more problem solving, and as you can imagine, potentially more resolution as well. And I'll just highlight here that I'm just pulling out the findings that the male and female partners both agreed on. So these are kind of the most robust findings from that data set. And then I'll kind of take a step back and just report on some additional broad factors related to relationships and health. Not surprisingly, romantic partners demonstrate similarity along many behaviors and factors related to health. These studies have covered everything from taste and smell preferences to the use of sunscreen, to diet, exercise, and substance behaviors. So really fundamental behaviors that shape how people age over time. And these connections are particularly strong in midlife. People have had more chance to kind of come together and to learn from each other. And so I think this points to the importance of having a potentially healthy partner at this point in the lifespan. Really fascinating is research that takes these associations a step further and finds that our romantic partners play a uniquely predictive role in determining how we behave. There are some studies that show that it's how your partner feels or what your partner believes that predict the other person's health outcomes even more so than their own preferences. And that's that's been shown several times in exercise adherence programs, for example. In midlife, we see evidence that it's your partner's chronic stress that predicts your increased waist circumference over a 4-year period, more so than the stress you report yourself at that earlier period. Another really important study looked at over a 10-year reporting period and showed that it was the partner's drinking levels at one point in time that were more predictive of the partner's outcomes, even controlling for that partner's original drinking levels. So we're kind of shaped and we develop alongside our partners in response to what our partner thinks and feels and how they behave, even in midlife. And so these are really important factors then for how people just continue the life course. I wanted to end with some takeaways, both in terms of relationships as well as just general health. So this is a slide that comes from a textbook I use to teach an intimate relationships class. When I went to this list that the authors, Tom Bradbury and Ben Carney, have compiled over the years, these apply to relationships at all stages of life. When I looked at them a little more closely, I think they also apply to many types of relationships, not only our romantic relationships. And the main, if you take these specific factors and summarize them, they really boil down to be a good person and be a good partner. And give your partner the benefit of the doubt as much as you can. Be as healthy as you can. And communicate as well as you can. And that's not to say don't have differences, but we know that there are ways to handle differences that are better for you and the relationship, and therefore make those issues less likely to come up. When I tried to summarize what research on healthy aging tells us, there are factors that we've already heard about some of them here, and the list won't surprise you. Midlife is really, really important. So when I was going into these specific factors, smoking status, for example, if you don't smoke in midlife but have smoked before, that's still a very positive sign. So there's something about midlife that really can help predict how we age. Physical activity levels, which we've talked about today, body mass index, diet, health practices. There are a wide number of things that we can do in midlife to develop in healthy ways. We should have policies that allow us to encourage people to improve these health indicators at multiple points throughout our lifespan, acknowledging that earlier development can impact later development. I think the findings point to additional screening for drug use and its consequences among midlife individuals. And I think the research is pretty clear. We could do more to take advantage when people are in committed relationships in midlife to find out more about the partner's health status or preferences or activities, as a way to maybe intervene on an individual's behaviors as well, and potentially just increase the effectiveness of programs at this point in the life. Okay, thank you so much, and we have little time for questions.